Okay, let's go ahead and get started. Good afternoon, everyone. Welcome to Medical Grand Rounds. It's good to see all of you. This has been a Medical Grand Rounds that I've waited for about 8 years, actually. I've looked forward to this talk for a while. Mary Bessesen, as you know, is a professor of medicine in the Division of Infectious Diseases. She's also the chief of the ID division/section at the VA hospital, and has been with us for a long time, since 1985 as a faculty member. She did her undergraduate and her MD degree at the University of Kansas, and then came here as a intern, resident, and fellow. Completed fellowship and then came on faculty in 1985. And since that time, which I guess is like 32 years ago, wow, that's a long time. She has had a profound effect in several domains. In medical education, she has focused on house staff training as well as fellowship training, has developed several programs in those areas. She has spent most of her time at the VA and has developed an outstanding service at the VA and leads an outstanding service at the VA. In terms of her research, she has begun to focus on the microbiome in the nares and the effect that this has on Staph aureus colonization and infection. It's really a pleasure to have someone like Mary as a faculty member, because she embodies the tripartite mission of the department. And she has really worked hard in a persistent way to excel in all of those domains. So please join me in welcoming Mary.
Thank you, Dr. Schwartz, for that kind introduction. It's a testament to the advancement of women in this department that Dr. Schwartz is not afraid to allude to the age of one of his female faculty. But I appreciate all of you coming out today to hear about a disease that probably everyone in the room has seen, a disease that we all care for in the inpatient service and yet continues to challenge us both clinically and scientifically. I'll start with a case, actually two cases, as is traditional for Medicine Grand Rounds. The first is a 50-year-old man presented to the emergency department with fever, malaise, had no localizing symptoms, and was discharged with a diagnosis of viral syndrome. He returned 3 days later to a different emergency department where he was found to be febrile, tachypnic, tachycardic, and hypotensive. On exam, he had a left knee effusion and left triceps weakness. Blood cultures were drawn, and empiric therapy was begun with vancomycin and piperacillin tazobactam. And at 12 hours, the blood cultures were reported positive for gram-positive coccidioidan clusters. An MRI of his spine shows nice regular thoracic vertebrae. You get up here into the cervical spine and you see a lot of cortical irregularity and a fluid collection here with gadolinium enhancement consistent with an epidural abscess. He underwent surgical drainage of the abscess as well as washout of the left knee. And on day 3, the blood cultures were reported as Staph aureus resistant to oxacillin. Antimicrobial therapy was narrowed to vancomycin, and over the next several weeks, he had repeated abscesses of his muscles and joints, requiring multiple surgical debridements. A transesophageal echocardiogram was negative. Blood cultures remained positive for 8 days, and eventually he was switched to salvage therapy with high-dose daptomycin and ceftaroline, received a total of 10 weeks of therapy. He regained his health and returned home with his wife. The second case is an 80-year-old man with well-controlled HIV disease, had a positive nasal screen for MRSA in 2010, and over the next 7 years had 7 repeated positive screens. And during that time, his only complication was a skin abscess that was treated with incision and drainage and no adjunctive antimicrobial therapy. He underwent a total hip arthroplasty in 2017 without any complications. So this illustrates somewhat the spectrum of what we deal with this organism. Over 30 years ago, before I joined the faculty, in the New England Journal of Medicine, a review article was published on Staph aureus called The Persistent Pathogen. It's really an apt description. It persisted clinically in both of our cases. In one case, with very prominent clinical manifestations. In the other, as simply an asymptomatic colonizer, but persistently present. Man's been co-evolving with this organism for centuries. The first clinical description of Staph aureus disease was in the Old Testament. It was described microbiologically in the 19th century in the golden age of light microscopy, and we continue to try to tease it apart and get the upper hand over it. So I'm going to focus on clinical issues today, so breathe a sigh of relief. You can stay when you finish your lunch. We'll talk about some diagnostic issues, blood cultures, echocardiography. We'll talk about antimicrobial therapy, and then I'll turn to some epidemiologic questions. So blood cultures, appropriate to start here. This is how we diagnose it. But why does it take 3 days? That's an eternity in modern medicine. So let me just run through how they work, and I will welcome any corrections from Dr. Mattinger. So we put blood in a bottle of broth. We put it in an incubator that has a mechanism that automatically detects products of metabolism, and when they detect that, it alarms. The tech comes, takes a sample from the bottle, does a gram stain, sees this, and calls the clinician and says, you have gram-positive cocci in clusters. So you know the genus, you know it's Staphylococcus, but there's a lot that you don't know. And in particular, that question that clinicians most want the answer to, what can I treat it with that's going to work? You certainly can choose vancomycin, and most people do, an agent that is reliably active against this organism, but not the drug of choice for organisms that are sensitive to beta-lactams. The tech also takes a sample from that bottle and puts it on an agar plate and incubates that, waits a day, and then they have this. You see individual colonies. And they take one of those and do either a phenotypic method, which takes another day to identify it. They may use proteomics and get you an answer in an hour or so with MALDI-TOF. The classic next step is to do what's called a coagulase test. Actually detects clumping factor. And if you see clumping here, it's Staph aureus. If you don't, this is your negative control. It's a coag-negative staph. So all of this takes many steps, takes 3 days. You can speed this along, and in just the last few years, some nucleic acid methods have been implemented in many labs that will at least here at this initial stage, when they first call you with the gram stain, they can apply a method that will tell you this organism has a MEK-A gene, it's MRSA, and that can be very helpful. What about those coagulase negative staph? Not the primary topic today, but they confuse people, so I'll talk about them for a minute. Some labs will report a species name, and others will simply call it coag-negative staph, unless it's Staph lugdunensis, which is more pathogenic than these others. These other species, by and large, you can lump them. Clinically, they act pretty similarly, and that's why many labs will simply call them coag-negative and not bother to give them a name. If you work at a place like that and then you go to a hospital that gives them a name, it may worry you the first time. Oh, it must be something special. They gave it a name. But in fact, it's just a coag-negative staph. People also get confused about how to interpret the blood cultures based on number of bottles, because there's evidence, good evidence, with the coag-negative staph that if you have a single positive, that's almost always a contaminant. In this Weinstein paper, 100% contaminants. Whereas if there are multiple positives, that might be a true pathogen, and you need to evaluate the case clinically to decide that. Whereas Staph aureus, whether it's a single positive or multiple positives, it's almost always a pathogen. One of the most significant complications of Staph aureus bacteremia is bacterial endocarditis. You see the vegetations here on the valve. Okay, I don't have a fancy audience response system, so this is a safe space. We'll do show of hands. The proportion of patients with Staph aureus bacteremia who have endocarditis, who likes A, 5%? Couple, okay. 9%? Few more, okay. How about 16%? Got a few, okay, 29? All right, good. Well, here's the good news. You're all right. So, we love to be right in medicine. The answer is it depends how hard you look. So this is 3 different studies, one of them with 2 cohorts, looking at prevalence of endocarditis with people with Staph aureus bacteremia. So this first one by Kosh, there's a European cohort, and in the blue bar is how many got an echo, and in the yellow bar is how many they detected endocarditis in. So in the Europeans, 39% got an echo, and 4.3% had endocarditis. In the American cohort, 58%, I believe it was, got an echo, and 9% had endocarditis. In this study in the UK, where they line up for things in the UK. The way they did this was the microlab, when they got a positive blood culture for Staph aureus, would send the name to the echo lab where they would put the patient's name on a list to get an echocardiogram. And they got one in almost 60% of cases, and it's I think 17% had endocarditis. And then this last one by Inkani in Northern Europe, a whopping 82% had transesophageal echoes, and they found endocarditis in 29%. Now, the argument has been, if we find a tiny little something on an echo, is that the same disease as someone with obvious clinical bacterial endocarditis? And we don't have an answer yet to that question. So transesophageal echo is invasive, requires conscious sedation. 1 in 5,000 will have an esophageal rupture. So, is there some other way to do this? Could we use a non-invasive test? And, the first study that got some of the controversy going by Vance Fowler back in the mid-90s used TEE as the gold standard, so 100% sensitivity for transesophageal echo. And among those who also, and the transthoracic echo in that group only detected 27% of the cases of endocarditis. But echocardiography has improved since then, and a recent study looked at this again. This is not all Staph aureus bacteremia, but it's a comparison of transthoracic to transesophageal echo sensitivity. And in the people who had a good quality study, the transthoracic echo detected 84% of the cases that were found on transesophageal echo. If it was a poor quality study or if there were valvular abnormalities at baseline, the sensitivity goes down to 70%. So it's a single center study, and it's not very large. Between these 2 studies is not even 100 patients. And you wouldn't want to miss 30% of cases. So TTE has gotten much better, and if it's a good quality study in a low-risk patient, it may be adequate, but we'd like to see more data. So can we use our clinical judgment to decide who we need to do an invasive TEE on and who can get by with a transthoracic echo? And people have looked at a number of risk factors, most important being persistent bacteremia, hemodialysis patients in some series that have an increased risk for endocarditis, any kind of intracardiac device, be it a prosthetic valve, an implantable defibrillator, certainly anyone with physical exam findings for endocarditis, like Roth spots, Osler's nodes, Janeway lesions, Now, in modern series of endocarditis, those are only present in less than 10% of cases. But if they're present, they certainly raise the suspicion greatly. And then lastly, one that may be counterintuitive at first is community-acquired bacteremia. Typically, nosocomial disease is worse, mostly because it attacks people who have comorbidity. But in this case, if someone has community-acquired Staph aureus bacteremia, their risk of endocarditis is higher than a person with nosocomial bacteremia, possibly because we detect it earlier. So when might we be able to defer the transesophageal echo? Well, if they have none of these risk factors, so if their blood cultures are negative at day 4, if there's no intracardiac device, if it's a nosocomial bacteremia, the likelihood that that patient has endocarditis is less than 5%, and it's possible to defer. Some would add additional risk factors like no secondary focus of infection, and that certainly is predictive of endocarditis. On the other hand, if they have vertebral osteomyelitis, you know you're going to treat them for 6 weeks. And so if there's nothing clinically suggesting a complicated endocarditis, that might actually be a reason not to do the test. And of course, if there are no clinical signs of endocarditis. And lastly, in some series, if the patient is not on hemodialysis. The Fowler series, again, is 20 years old. I think there are tremendous advances in hemodialysis, improvements in line access, many fewer patients getting dialysis through tunneled catheters, and many more through fistulas. So the risk of endocarditis perhaps is not as high as it was when some of these older series were done. So let's move to antimicrobial therapy, and we'll divide this by methicillin susceptible and methicillin resistant. So we have 3 basic options for methicillin susceptible Staph aureus bacteremia. There's the anti-staphylococcal penicillins, nafcillin, oxacillin, and in Europe and Australia they use flucloxacillin, which is essentially the same thing, cefazolin or daptomycin. And in much of infectious disease, and Staph aureus bacteremia is no exception, we don't have a lot of randomized controlled trials. HIV, of course, is an exception. But in much of routine ID practice, a lot of what we do, unfortunately, is based on observational studies, and this is no exception. We do have one good quality, prospective randomized comparative trial of standard of care therapy versus daptomycin. Colorado was actually a site in this trial. And they took both methicillin susceptible and methicillin resistant staph. This is the registration trial, or at least the trial to get a bacteremia indication for daptomycin. At the time, it was felt by the investigators that the standard of care for methicillin susceptible Staph aureus bacteremia was an anti-staphylococcal penicillin plus 3 days of gentamicin. So that was the comparator arm. And it was designed as a non-inferiority trial. Daptomycin was shown to be non-inferior for the group overall, well below the 20% cutoff that they used for non-inferiority. If you come down here and look at methicillin susceptible staph, it slightly favored the standard of care. And in fact, if you look at the confidence interval, it even crosses that 20% for susceptible staph. So daptomycin is certainly an acceptable drug for methicillin susceptible Staph aureus bacteremia, but some would ascribe it a second-line role. What about cefazolin? I was taught as a fellow that it's much better to use the anti-staphylococcal penicillins, that there's an inoculum effect that works against you when you're using cefazolin. And for that reason, many people have preferred nafcillin as the drug of choice. And there's never been a randomized controlled trial. But there are several recent observational studies. This one looks at cure at end of therapy. You've got cefazolin here in the blue bar, oxacillin in yellow, no difference. Mortality, 1% versus 3%, actually slightly higher for oxacillin. not statistically significant, but toxicity significantly higher for nafcillin than for cefazolin. What were those toxicities? Rash in 14%, renal impairment in 11%, LFT abnormalities, neutropenia. All of these are statistically significantly worse for cefazolin. One would expect that perhaps the narrower spectrum agent, the penicillin, would have less C. difficile, but in fact there was no significant difference. There was a trend towards nafcillin actually being a little bit worse. Now, the argument is we put the sicker patients on nafcillin. We're more worried about them, so of course they're going to do worse. So an attempt was made to correct for this in another study where they did propensity score matching and compared them and found no difference in clinical failure at 4 weeks or 12 weeks, no difference in mortality, but again, much more adverse drug events with nafcillin than with cefazolin. One big exception to the use of cefazolin still is that it does not penetrate the blood-brain barrier as well as nafcillin. So when endocarditis or staph bacteremia is complicated by a brain abscess, it is preferred still to use nafcillin or oxacillin, an anti-staphylococcal penicillin for that case. Okay, before I go into antibiotics for MRSA, I want to talk for just a moment about mortality with MRSA versus MSSA. And this has been studied now for a couple of decades, and virtually every study shows higher mortality for MRSA, about double. Now, is that because MRSA is a nosocomial pathogen? It impacts people with a lot of comorbidity, and that's why their mortality is higher? In this meta-analysis, they attempted to correct for that. I think there are some 16 studies here. And overall, the odds of mortality with MRSA were about double MSSA. And when they adjusted for comorbidity, for age, and all of the factors that they could, still the odds for mortality with MRSA were significantly higher, odds ratio of 1.5 compared with MSSA. So why might that be? It's the same bug, it just has this resistance mechanism for the most part. And so it may be that we don't have quite as good a drug for that. So let's look at the impact of these drugs on methicillin-susceptible Staph aureus. And here you find that in vitro, bacterial killing is slower with vancomycin. In vivo, there's poorer tissue penetration. You clear bacteremia more slowly, and there's higher mortality. So at one time, vancomycin was used as a drug of convenience for Staph aureus bacteremia because of its longer half-life, and that's no longer recommended for this reason. So what are our choices? Really, the two main choices are vancomycin and daptomycin. There are other drugs with activity, and I'll talk about them briefly. Trimethoprim sulfa, ceftaroline. I won't show you a study. I'll just tell you that this is a new fourth-generation cephalosporin that actually binds to the PBP2A, the penicillin-binding protein that's altered in methicillin-resistant staph, and has activity. It's been used in salvage situations, and there are case series of its use for bacteremia, and it can be considered an alternative agent. And then I'll talk a little bit about combination therapy. So again, this is the study I showed you earlier, daptomycin versus standard of care. In this case, standard of care was vancomycin, and no difference between the two. So daptomycin is certainly a good option for methicillin-resistant Staph aureus bacteremia. Bactrim was looked at many years ago in this country and found to be inferior, but the study was done again in Israel just recently. And this was designed as a non-inferiority trial of trimethoprim sulfa versus vancomycin for serious Staph aureus infection. Most of the cases were bacteremia. And they found that at 7 days, failure was higher in the Bactrim group, not statistically significantly higher, but didn't meet the margin of error for non-inferiority. Same thing at 30 days, higher mortality with trimethoprim sulfa. So this drug cannot be recommended for Staph aureus bacteremia. What about combination therapy? I mentioned earlier that 20 years ago we thought the standard of care was an anti-staphylococcal penicillin plus gentamicin for MSSA, and perhaps even adding it to vancomycin. And it does clear bacteremia about a day faster, but there's no mortality benefit and there's more kidney injury. And so this practice has been pretty much abandoned. What about rifampin? There was a recent trial published in Europe, the reference is at the bottom here if you're interested, where they randomized people to standard of care therapy plus rifampin or placebo. And what they found was there was no difference overall in failure or death. There was a trend towards benefit in the 40% of the population that had a deep tissue focus of infection. They had more drug interactions, but it was surprisingly few. It was 6% versus 2%. But at this time, rifampin is not recommended as adjunctive therapy for Staph aureus bacteremia. May be used for certain cases of deep tissue infection, particularly people with a prosthetic joint, generally after the bacteremia has cleared. And then as I step further and further into the thin data zone, I'll talk a little bit about vancomycin or daptomycin combination therapy with a beta-lactam agent. So before I do that, let me just review quickly how these antibiotics work. So this is staphylococcal cell wall here, these yellow lines of the outer and inner part of the cell wall with these peptidoglycan chains in the little blue balls. And those get cross-linked by the penicillin binding protein, making for a stronger cell wall. So we come along with methicillin, bind to this penicillin binding protein. It can't do its job. The organism then acquires a MEK-A gene that codes for a different penicillin binding protein, PBP2A, and methicillin is not able to bind to it. It doesn't work. And the penicillin binding protein is able to do its job, cross-linking those chains. So we come along with vancomycin, bind to that altered penicillin binding protein. The organism then comes back with a very thickened cell wall, such that when we treat with vancomycin, it kind of gets bound up in that thickened cell wall, and it doesn't work. After a while, the organism stops making that thickened cell wall. It doesn't need to anymore. And it goes back to making the native penicillin binding protein. So at that point, we can come back with methicillin and get potentially some synergy. Okay, how does daptomycin work? It's also a cell wall active agent, but that's daptomycin there in the little blue pentagon poking a hole in the Staph aureus cell wall. The organism responds to this too by increasing the positive charge of the cell wall so that daptomycin can't bind as well. If we add nafcillin, then that positive charge goes away, and then daptomycin is again able to work. So 3 mechanisms of potential synergy: reduced transcription of MEK-A, called the seesaw effect, enhanced daptomycin binding because of the change in the charge of the cell wall, and then interestingly, some host peptides, particularly this cathelicidin, LL37, also binds better in the presence of nafcillin due to that charge effect on the cell wall. So the LL37 is fluorescent here in red, binding to the organisms. So what's the clinical impact of this combination therapy? We can use it in salvage regimens, as we did in the case that I presented. It's certainly not first-line therapy, although it has been studied for that. This was a recent paper from Australia where they took patients with MRSA bacteremia and randomized them to vancomycin with or without flucloxacillin, would be nafcillin or oxacillin if we were in the United States. They enrolled 60 patients, unselected patients with Staph aureus bacteremia, MRSA bacteremia, and they showed that when they gave combination therapy, the duration of bacteremia was shorter. So here we have clearance of bacteremia going up, time on this axis, clearance of bacteremia. So the red line with combination therapy, they cleared faster than the people on monotherapy. Now, here on day one, more than half the patients had already cleared their bacteremia. Now, we don't know that clinically yet. We're standing there on day one. We've got the blood cultures in the incubator, and we don't know yet that they've cleared. They're only able to gather this information later. If we could figure out who are these people early, who are these people who are not going to clear, we may be able to target this intervention a little bit more effectively. But even in this unselected group, there was a strong trend towards the combination therapy clearing bacteremia faster. No difference in mortality, but no toxicity difference. So this is a similar benefit to gentamicin. We abandoned it because it was too toxic, with nephrotoxicity particularly. But here, with no impact on toxicity, we can probably clear bacteremia faster, and in a larger trial, we might be able to show some clinical benefit. So I've been talking a lot about management of the individual patient. Let's move now to some population data. This is a study that Alex Callan, who was former faculty here and now at CDC, did looking at MRSA bacteremia in the United States. They looked at several cities that enrolled in the Emerging Infections Program and then extrapolated from those data to make some estimates for the country as a whole. But he showed between 2005 and 2008 about a 9% per year decrease in MRSA bacteremia, healthcare associated. So what's going on here? Not a randomized trial, of course, but this is right after the Keystone Project was completed and publicized, and hospitals were implementing infection control bundles to reduce central line associated bloodstream infection, and likely that's why these rates were going down. Now, they estimated that there were nearly 19,000 deaths from MRSA bacteremia, or invasive MRSA infection, of which 90% are MRSA bacteremia. And they pointed out that that year that was more than the number of deaths due to AIDS. And MRSA bacteremia is about half of the bacteremia. So you can roughly double these numbers if you want to think about how many cases of Staph aureus bacteremia there are in the country every year. Okay, another audience participation. The 30-day mortality of acute myocardial infarction. Who likes 5%? Okay, 10%? A lot of hands, good. 20%? Okay, 30%. Nobody. Okay, good. Staph aureus bacteremia. 5%? 10? Few hands. 20? Few more. Okay, 30? Okay. So the obvious point here is this is a serious infection, a serious disease. You know, myocardial infarction is, of course, a dreaded disease, but you never hear someone say, "Oh, I thought I was going to have Staph aureus bacteremia." And yet we should take it as seriously clinically and give it our undivided attention. This is a study from the VA Corporate Data Warehouse. So the largest study to date of Staph aureus bacteremia. This is both resistant and sensitive Staph aureus over a 12-year period. And they showed the same thing that Alex Callan showed with decreasing incidence. Here, the blue bars are number of cases, and continues that trend. His study went up through 2008, but even all the way through 2014, number of cases are going down. Good news. And the mortality per case also going down over time. So we're doing something right. And what are we doing right? These were the processes of care that they looked at that were associated with decreased mortality. So appropriate antimicrobial therapy, no surprise there. You give the right antibiotic, 26% decrease in mortality. If you get an echocardiogram, 27% decrease. And they didn't distinguish here between transesophageal, transthoracic. Any echocardiogram counted. If you got an ID consult, 39% decrease in mortality. Now, there have been many studies of the impact of ID consultation on outcomes in Staph aureus bacteremia. Tim Jenkins did one here when he was a fellow. And so what's this consultation doing? It's not opening up the left anterior descending artery. So it's not as obvious. But the things that they found were people who got an ID consult are more likely to get the right antibiotic for the right period of time, to get lines removed, to get abscesses drained. And with that, there's a pretty substantial decrease in mortality. And they also showed that these processes of care went up over the period of their study. Right antibiotic went from 68% up to 78%, and echocardiography and ID consultation went from the mid-30s back in 2003 up to nearly 70% in the present day. Okay, so that's the first case. Let's talk for a few minutes about Staph aureus colonization. And by definition, it's asymptomatic. The case I presented to you suffered almost no consequences. So why are we talking about it? Well, it turns out that if you come in the hospital and you have a positive swab for Staph aureus on admission, your risk of bacteremia during the hospital stay goes up threefold. And the bloodstream isolate matches the nasal isolate 80% of the time. So it's not just that these people are covered with staph, they're covered with a particular staph. It's also a source of transmission to other people. There are three patterns of colonization. There's non-colonized, about half the population. You can be intermittently colonized, so you swab people over time, some positives, some negatives, or persistently colonized. And there's a lot of variation here in studies. So the non-colonized from 60% to 69%, intermittently pretty similar, low of 16, high of 70, has to do partly with the population study, but more importantly with how hard you look. How many swabs do you get? How carefully do you culture them? Persistently colonized, a little bit narrower range there. So it's a pretty good number to carry around in your head that about 20% are colonized persistently. Does it matter? You know, it used to be thought, based on some data in people with end-stage renal disease, that only the persistently colonized people were at increased risk for invasive disease. But this is a study that Dan Vigil did when he was a preventive medicine resident here. He took our database at the VA based on our active screening for colonization program and looked at their risk of invasive disease. In the non-carriers, it was 0.7%. Intermittent carriers, I think it was 11% versus about 14% in the persistent carriers. Difference between each of these was statistically significant, but still the intermittent carriers had a very significant risk of disease. So why are some people colonized and some not? Does the immune system play a role? This is a look at the humoral immune system, where you've got antibody level concentrations on the y-axis and various staphylococcal proteins in each of these columns along here. And you've got your persistent carriers displayed as red triangles, intermittent as green diamonds, and the non-colonized people as blue squares. And you know, this is like you took your paints and threw it at the graph. Really, there's not much impact of the humoral immune system, except for toxic shock syndrome, toxin 1, where interestingly, the persistent carriers had higher antibody levels than the non-carriers. So the organism's presence has stimulated the humoral immune system to respond, but it's not able to clear the carriage. But the immune system is, of course, has multiple components, and people have done genome-wide association studies looking for SNPs associated with carriage, and they've found some in places that make sense, like TLR2, the glucocorticoid receptor, C-reactive protein, IL-4, and a promoter region for beta-defensin. So there's no smoking gun here. There's no single gene defect in the immune system that explains why some people are colonized and some are not. There's just a number of small factors that altogether add up to some people being colonized. Does genetics play a role? This was a study from Denmark where they have a twin registry, and they were able to recruit 617 middle-aged and older twin pairs and look for concordance. So if one is colonized, is the other one colonized? It was surprisingly low. In the blue column there are dizygotic twins that are same-sex, only 24% concordance for colonization. In yellow there are the dizygotic twins, different sex, 21%. The monozygotic twins had somewhat higher concordance at 37%, but these differences did not achieve statistical significance. So the genetic impact on colonization, if present, appears to be small, at least in this kind of whole human study, if you will. We wondered if the nasal microbiome might play a role in Staph aureus colonization and disease. This is a study that I did with Dan Frank, where we took our patients who had persistent colonization, defined as 5 or more swabs, of which at least 80% were positive, or of which all were negative. And we have displayed here on this analysis of their microbiota, the colonized patients as red dots and the non-colonized as blue triangles. And the graph is an attempt to collapse some pretty complex data, the entire population of organisms in the nose, into a single spot. Where the spot lies on the graph is one individual person's nasal microbiota. And you can see that there's significant difference between colonized and non-colonized. And some particular individual organisms, streptococci especially, that were associated with the non-colonized state. We then looked at incident colonization. So those were people who were colonized for a long time, and you could ask what's cause, what's effect, does the Staph aureus have an impact on the microbiome as opposed to the other way around? So we took people who came into the hospital non-colonized and took their serial swabs over time and looked at their microbiota. And this is an index of the diversity of the microbiome, how many different organisms are present and how is the relative abundance of each of those organisms. And it's boiled down into a number called the Shannon index here. The higher the number, the more diverse the microbiome. So the people who resisted becoming colonized had a pretty diverse microbiome coming in, and through their hospital stay, it didn't change. Whereas those who became colonized here, or came in non-colonized, remained non-colonized here, but their diversity had gone down, and then here we are at time 0, they've now become colonized. So, you know, there are many things in the hospital environment that might reduce the diversity of our microbiome. Antibiotics are obviously high on the list, antiseptics, stress, surgical procedures. This study wasn't large enough to be able to tease out what those factors might be, but in the human microbiome, as in life, diversity is a good thing. So I'll take you back to this graph that I showed you most of earlier about people's colonization phenotype, non-intermittent or persistent. And then bacteremia, you know, it's 1 in 2,000. You can't even see it on the graph. So all of these people who are persistently colonized, they're at increased risk of infection, but it doesn't happen very often. And we wondered about that. Why is that? Oops. So Charles Darwin said that the species that survives is not the strongest, but the one who's most adapted to the environment. We wondered if the organism was somehow evolving in the nasal niche to allow it to become more virulent and invade. Oh. Yeah, okay, sorry, picture didn't show up. So we'll skip over that one. Staph aureus has a number of toxins, a number of virulence proteins, not all of them toxins. And not every species is the same, or not every strain is the same. And they express those differently through their life cycle. So early in the life cycle, the number of organisms is low, and over time on this axis, the number of organisms is going up. It goes through this exponential growth phase, and then it kind of reaches a point where it's used up the space or consumed the nutrients, and growth levels off. So at that point, the organism switches its focus, if you will. I'm anthropomorphizing here, but it switches from expression of proteins involved with metabolism to production of toxins. And that's regulated by this accessory gene regulator, AGR. So we took 8 patients that we had serial nasal samples on who progressed to bacteremia and did whole genome sequencing on their isolates to see what happened over time as far as evolution in the nares. And what we found was one case of a mutation in this accessory gene regulator, which resulted in decreased toxin production, which initially is counterintuitive. You would think that increased toxin production would equal increased virulence. But in fact, if the organism is going to survive in the bloodstream, it's probably better off making less toxin. And if you look at case series of persistent Staph aureus bacteremia, the majority have AGR, accessory gene regulator, dysfunction. But in 7 cases, the bacteremia occurred just in the setting of medical care. Central venous lines, surgery, tube thoracostomy, the things that happen to patients in a medical care setting were the main risk factors for Staph bacteremia. So although Darwin said that the species that survives is the most adaptable to the environment, I think that in the race between the pathogen and the host, it's the highly evolved human brain that tilts us towards success. And we express that by doing things right. The infection control measures that we've implemented that have decreased the incidence of bacteremia, the management methods that everybody in this room participates in and does a nice job of, that reduce mortality in those people who do develop Staph aureus bacteremia. So I'll close by acknowledging my division, especially the fellows who see these consults, and the many faculty who could have done at least as good a job giving this talk as I have. Special shout out to Dave Cohn, who helped me out with something I'd been looking for years. So I'll close there and take questions.
Thanks a lot, Mary. I'm sure we have a number of questions. Let's go with the house staff first.
One of the antibiotics, sorry, I'm Mike, I'm one of the house staff. One of the antibiotics that we didn't see on that presentation was linezolid. Is there any role for linezolid in Staph bacteremia, specifically MRSA?
Thank you. So the question is about linezolid, agent that is available both orally and intravenously, has good Staph aureus activity. But it's a bacteriostatic antibiotic, and in trials where it was used where people had Staph bacteremia, mortality was actually higher. So it is not recommended for Staph bacteremia.
Mary, you mentioned some genetic factors in the host. What about comorbidities, and how do comorbidities play into the colonization of the nares?
Yeah, that's a good question. Comorbidities play a big role in the colonization of the nares. Diabetes, end-stage renal disease, age, bimodal for age. That's not a morbidity, of course, but infants have a very high prevalence of colonization, and in our practice of adults, colonization goes up with age. The very elderly have a much higher prevalence of colonization. So yes, comorbidity is definitely part of it. However, perfectly healthy people can also be colonized and infected with Staph aureus.
Okay, there's another question in the back.
Hey, I'm John. I'm one of the R3s. You touched on at the beginning of your talk new molecular diagnostic tools for identification of Staph aureus. How do you see that playing out and changing clinical practice in the coming years?
Yeah, the question is about using our molecular tools. You know, what you'd really like is an instantaneous molecular tool that you could apply at the bedside. And that is not close to being available. But I do think that as the evidence grows that vancomycin is a less active agent than the beta-lactams, I think that we will perhaps be more willing to switch or at least to add a beta-lactam when the molecular assays, now available as quickly as 12 or so hours after getting the first culture, tell us that the MEK-A gene is absent.
Mary, from one of our house staff over at PSL, they're curious if there's any evidence behind contact precautions for our MRSA colonizers.
The question is about contact precautions for prevention of transmission of methicillin-resistant Staph aureus in the inpatient setting. The evidence that we have is observational. It comes from the VA, where they implemented a bundle of processes to reduce MRSA, including screening for colonization and contact precautions for people who are colonized, but also included surveillance and reporting of MRSA infections and all the improvements in processes of care in terms of central line bundles, ventilator care bundles. And so how do you tease out from that the impact of contact precautions versus all of these? The answer is it's difficult to do. There was one randomized trial of contact precautions alone as a single intervention. It was performed in ICUs. I think it was called the STAR ICU trial. And in that study, it didn't help. But the study was deeply flawed because there was a long delay between the initial swab and getting the result. They decided to use a central lab. And so by the time they sent that swab off to the central lab and got the result back, it was 2 days later. My personal view is that all Staph aureus are pathogenic or potentially pathogenic, and we should use careful processes with everybody. And when you put people in an isolation room and everybody that walks in has on a yellow gown, it's really hard on people. And yet there are states that mandate it. And the Veterans Administration has mandated it, and so it continues to occur in a lot of settings.
Question loosely related to contact precautions. Are healthcare workers like this audience at increased risk for colonization?
If I got the question right, it was, should healthcare workers be screened for colonization? Or you would increased risk? That has been looked at too, and the increased risk is minimal, if any.
Why? Well, go ahead, David.
Mary, great presentation. So just a word about the use of semi-synthetic penicillins versus cefazolin, taking us back to when we started to first use these in the 60s and 70s after development. The ID bias at that time was, well, of course we should use the semi-synthetic penicillin over cefazolin, because at that time cefazolin was, quote-unquote, a broad-spectrum antibiotic. We don't think about it that way now, but at that time we did, because Staph aureus was gram-positive, semi-synthetics are gram-positive only, and cefazolin had activity against gram-negatives as well. As time went on, of course, cefazolin is now considered, relatively speaking, narrow-spectrum, and it's kind of surprising that the randomized trial that you alluded to never got done. And it took us a while to realize that there's toxicities involved with nafcillin and oxacillin, and cefazolin is an extraordinarily non-toxic drug, and of course we use it a lot now. So it took that period of time, but the original bias was, and it still is for ID, use the narrowest spectrum agent available if you can, as long as it's safe and efficacious.
Thank you. That was wonderful. And I don't want to divert us, but you mentioned the use of gentamicin for synergy. And I'm just wondering, where is gentamicin still used for synergy, and single daily dose versus continuous infusion versus other alternatives? Is there any use of gentamicin these days for Staph aureus?
There's very little use of gentamicin for synergy for Staph aureus. I think that If we didn't have these data about the combination of other agents, you might defend it in a case where bacteremia was not clearing, that it's worth taking the risk of some nephrotoxicity to clear the bacteremia. But we now have other agents that we can use in combination. So I really think the use of aminoglycosides, gentamicin in particular, for synergy for Staph aureus, there are very few indications for it anymore.
Why don't we screen every patient who gets hospitalized for colonization and just treat them at admission?
Why don't we screen them all for colonization with any Staph aureus? And
what's the thinking related to that, the pros and the cons?
I think that there's a cost there, that our tools for decolonization are limited. We have mupirocin, and there, of course, are mupirocin resistance genes. And mupirocin is not a narrow spectrum agent. It gets rid of a lot of organisms, which may then open the person up to influx of other pathogens. And if you decolonize a person and they have a high burden of illness, you follow them over time, they almost always become colonized again. So the best way to deploy these tools is to do it at the time of greatest risk. So if the person's having cardiothoracic surgery, joint replacement surgery, that's the time to decolonize them. You can get rid of it for the few days or a week or 2 or 3 of highest risk, and then if they relapse, or if they again become colonized, they're not at such great risk anymore. So that's kind of a vertical strategy, if you will. Then there's a horizontal strategy, which is rather than screening people and directing this, let's try to reduce the pathogen burden on everybody at high risk. So in the intensive care units now, in most places, nurses give people a bath with a chlorhexidine cloth every day that leaves chlorhexidine on the skin and reduces the burden. And there's good evidence for that strategy in those high-risk patients in intensive care unit settings.
Any other questions? There's one question in the back. Jonathan?
Jonathan Pell, one of the hospitals here. So what about in MSSA using ceftriaxone? A lot of these medications have frequent dosing, and it has challenging for our patients that don't have good access to care because of resources, et cetera.
Yeah, ceftriaxone has good activity against Staph aureus. It's dosed once a day. It gets good levels in bone, and I use it a lot for bone and joint infections. It doesn't maintain high concentrations in blood over time. People do use it for bacteremia. There is a case series showing similar outcomes with ceftriaxone as it compared to cefazolin for bacteremia. Relatively small study, but it's not a recommended first-line therapy because of the pharmacokinetics that make it favorable and convenient for outpatient management and for bone and joint infections don't favor it for bacteremia.
Mary, thank you very much. That was great.